surgeon doing
Never,
putting the pack in, whether they disturb the turbinate while he's
maybe.
doing that. Yeah, that's quite
Yeah,
possible.
maybe. Sika again. It's interesting. What interesting is that why it happened. Here's the defect. Here's the edge of the bone. Look, you see the edge of the bone here, and this is the defect. This there. So just lift that mucosa a little bit more. So you see how that fluorescein has been useful here, because that is very small and in an unusual place. So what I'm doing now, by just lifting all this mucosa, I'm refreshing it, all angles. So posterior defect here, anterior part of the defect, and medial and lateral here. So basically, this looks like it's about a couple of millimeters, really. Let's have a suction. Now, do we have a suction with a smaller head? So now we can see it better.
Yeah, you can see how small it is there in relation to the end of your suction, Hesham.
Yeah, it's smaller than the sucker head, which is about 3 millimeters. So that's why I'm using a smaller sucker. This is like a couple of millimeters, this one. Let's try that. Have a look at it. So the most important thing is just make sure that we have refreshing the edges. I'm going to use Duragen because this is very small. So I'll use Duragen. It's a bit too tiny to actually be able to get fascia in here. If you see, so here's that smaller sucker. So I measured them by the sucker head, by the way. So this will be 2 millimeter really. So if I show you, yeah, let's have the.
That's nice. We can actually see the fluorescein coming through there now.
Now we can see it because I removed the mucosa.
Yeah.
So awkward place to prepare. Yeah.
As you are just back from Wessex Fest course, any thoughts on butt plug technique?
About
the size of butt plug?
How do you measure it?
Butt plug, the fat plug technique.
Yeah, butt plug. So basically, you take fat, which usually is described by PJ Wormald. You take fat from the earlobe, the I need Duragen, and then you stitch it with Vicryl and you go through it with the length of a stitch. So when you pull the stitch, it shrinks. So basically, you put the piece of fat inside the defect, and then pull the stitch that tightens the fat in the defect and acts like a plug in the bath, basically. And it's fat, so fat will cause scarring for the tissue around it. So it heals that way. But it's very useful for fresh leaks, like intraoperative leaks, because they're still fresh. They want to heal anyway. So when you put that in, it heals very well. I think just for all the leaks like this, I wouldn't probably do it. But I'm just trying to put some adrenaline on it for a bit to dry it a little bit. Okay, so we need Duragen. So I'll prepare it with Duragen and mucosa basically, and we need the glue, please. So if you see this, if I put a nice plug of Duragen, which really creates healing because it creates that, it stimulates granulation tissue and so on, so creates scar tissue. So it helps. The neurosurgeons use it a lot. I tend to use it a lot in the smaller leaks. Larger leaks, I use fascia because it's a lot stronger. So I'd use it in a leak like this. It's also too small for me to take cartridge from the septum and put it here. So I put the Duragen, then I put some glue to seal it, then I put some mucosa, and it should be all right.
What glue do you use?
So there's two types of glue. There's T-Seal, which is you mix it and then you can use it immediately. The problem with T-Seal, it doesn't have it's like a transparent in a way. And then the other one, which is Dura-Seal. Dura-Seal is blue, so you can see it clearly, but also comes with a pump. The good thing about the pump that it pushes away and it doesn't clog the needle, so it doesn't block the needle. The other one blocks the needle very quickly. So nowadays, I prefer to use the DuraSeal, not the T-Seal. You used to use the DuraSeal originally all the time until the other one became available. So interestingly, in the past, people used acrylic, which is like Durabond and things like this, and that caused reactions like meningisms and so on. So people stopped using it. So we're sure now this is the only leak. We can't see anything else anywhere. So that's definitely it. You can see the anterior edge, the posterior edge. So, sorry, got a question?
Yeah, what post-operative instructions do you give the patient? So post-op, going back to the ward this evening, what do you tell them and how do you manage them?
So we get them to sleep head up, 30 degrees for at least 24 hours, ideally 48. We give them a laxative so they don't have constipation or push and stuff like this. We tell them not to carry heavy lifting things for about a month, and no heavy exercise for a month. We have neuro-ops, initially when the ward, neuro-ops as well. And usually I keep them for one night. I used to keep them for 2 nights, but nowadays we keep them for 1 night.
And what about giving antibiotics? Would you give antibiotics after this or not?
You do not because, that there's lots of data showing that antibiotics don't decrease the incidence of meningitis, but because we're using foreign material here, we're using a DuraGen, we're going to use gel foam, we're going to use Nasopore, all these things. So that's why I put them on antibiotic for a week. So what we're doing now is we're going to look and then take a small piece of DuraGen to plug this. So let's have the DuraGen. So there's a tiny thing, obviously. So I'm going to take a tiny piece. So also we need, this is the DuraGen. Comes in a sheet like this. And scissors. We'll also need some gel foam and Nasopore and then 140 and then small ones.
So Hesham, you're saying you pack the nose afterwards with Nasopore, or?
With Nasopore, but before the Nasopore, we'll put gel foam to protect the repair. Gonna have the 45 Blixley. So I tend to put one Nasopore, like the hard one, which is Nasopore 40 first, on the repair, and then a couple of other Nasopores underneath it, soft ones.
You don't use any BIF or Whitehead's varnish anymore, or balloons or anything like that anymore?
No. Balloons are useful again for post-neurosurgery. See, even this tiny thing looks big. So I'm going to make it smaller. So we used to use, in the past, until 2003, let's have scissors again. I used to use basically ribbon gauze covered in Whitehead's varnish, which is iodine and bismuth and stuff like this. And you put this pack tightly inside the nasal cavity for a whole week. We used to send the patient home with this pack and then bring them a week later for a general anesthetic to remove the pack. And that was a bit too much for the patient. Obviously, have 2 anesthetics and so on. The pack is very, very tight and so on. And then I started in 2003, 2004 using Nasopore. Absorbable pack, obviously can use any similar one. And it was fine. So since then we stopped. I never published that like specifically or separately, but we talked about it in the meetings for years and colleagues now do the same. So we don't use permanent packs anymore. So now I put this here. So it will be a bit fiddly, it'll be sticky, but you put it like this. And then now, seeker, please. So now we'll ease it inside the, and it's very safe to put this to ease it off into the cavity like this.
Hesham,
Yeah.
the delegates have asked this very interesting question. These patients with BIH, they have a leak, we repair the leak, but they are more also likely to have a OSA and they would be on a CPAP. So what is your advice on patients who have a CSF leak repaired and they are on a CPAP?
So we had exactly that, and recently actually I did. See what I've done now is inside the cavity, yeah? So now this is sitting inside the cavity and filling it, just make sure. The patient in CPAP cannot use the CPAP. So we get them to get an oral CPAP modified for them instead of the nasal one. And we have had a couple of patients like this, and we managed to get them an oral CPAP. So that is sitting inside that cavity. When you look at it, it does tend to seal it because it's quite thick, it's not porous. So now we have a glue. So I'm going to cover it with glue now. Okay, so watch this glue now, yeah? Is it on? On the pump, yeah?
The pump on.
Pump on?
Yeah, we can
Okay.
see it coming through, beginning to. You've got nice blue spray coming through.
More blue than this. Here we are. So that's enough, yeah? So that's it. Now let us dry a little bit. So the good sign when you put this and you look, if it's still leaking, then you have to put more. So let's have a suction here. So then I'll need the mucosa. Yeah, I need another gel foam. I'm gonna put another one above this because it's slight leak in the top. So let's have a tiny piece. I'll cut it already. Great. Let's have one, yeah, one small one with a Blixley. No, this is good because we don't need the small one. We'll cover it. So I put a little bit more above it. They all stimulate granulation. That's why they're very useful. Put this above it here. Yeah, and let's have the Rusk Seeker. That's good now. It's actually not leaking now. You can see nothing is coming here. Suction. Obviously, directly suction away from this, otherwise you suck the pair out. So that's okay. So I'm going to put the mucosa. Let's have the big piece of mucosa that got earlier, which is this one. Actually, this is useful. Have a base. It has the tab in it. It has a piece of bone in it. I think it's very useful to put it there. So I'm probably going to take part of it. Too much bone actually. So probably. Let's have a look about what else you have there. Maybe I just use the mucosa. It's about too thick, this one. We don't want to put anything too thick. Yeah, this is curved. Perfect, this one. It's a lot better. So let's have scissors. I'm just going to cut this bit. So I have a bit, remember I kept all this mucosa from the beginning. So I can use it. Forceps or something. Okay, so let's have the Blixley 45, and I'm just gonna give you this back. There's another piece here you may use. So then I'll use the glue again in a minute. So now I have another mucosa I'm gonna put on the repair. So we need gel foam and we need Nasopore 40 and like 2 Nasopore normal.
You don't have the standard use.
You only have standard, that doesn't matter.
You don't have cold.
You only have 40, wow, okay, fine.
So 240.
240s, yeah. Maybe 3 then. Let's have the Seeker first. We'll Seeker. So I'm covering with mucosa now. And this free mucosa, it doesn't actually disappear. It's the good thing about the nasal mucosa that it does regenerate, takes a bit of blood supply and sits there nicely. So it is very useful to use that. But you tuck it in properly, so it's sitting like I did with the Lothrop. This sits on top of this. Now there's the controversy about putting glue now or not putting glue now. I think I put glue. It's ideally you don't want to put glue between the layers, but the thing is here, I like to seal the gel or the Duragen within. So I put glue in the Duragen, but I left a little bit of the other Duragen without glue in the top here. So that will stick to it. And now that it's all sealed here, I'm going to cover this with glue. And then I'll leave it to dry, then I'll put gel foam, because gel foam will protect the repair and also creates granulation. So now, pump on. Oops. Can I have the secret? It's too strong, the pump sometimes. So gel foam is a protective layer. Yeah. In larger leaks, I use cartilage often. It's coming, is it coming? Oh, I'm pressing the wrong one. Okay, that's it. There we go. That's the blue stuff. We're just closing everything so it's tight and stuck in there. I think that's enough. I'll leave it like this. I'll leave it to dry. Just have gel foam. So in larger leaks, I use 3 layers. I call it an anatomic repair. We published that many times. I use fascia, scissors first. Fascia lata, then cartilage from the septum, then mucosa. So we just have the 45. I'm going to have to wet these first. So then I have 2 pieces of gel foam, which creates adhesion. Let's try to show you here. The gel foam is very sticky. If you hold it and you try to push it, it will just come out. It will stick to your forceps because has an effect. You have to wet it, otherwise it's impossible to put it in. So let's just put sirloins in a little. Yeah, I'll just get it. So it's gonna wet like this, otherwise it will just annoy you so much. So we'll put 2 layers to protect the repair, and then we'll put our nasopore. Now let's have the seeker. So as you see, like that. Another one. The other one I cut. And we just wet it as well. Let's just stick it in the saline. So another layer here.
Catherine?
Yeah.
As an idea, what do you think for the next Grace Live? Probably in a year's time, we could present all these cases that we did over the last 2 days and as a follow-up of them, annual follow-up, and see how they are doing. That would be a good idea, isn't it?
Yeah, no, I agree. I think that would be really interesting to see how everyone's got on since surgery, and it'll give people some feedback on what's been happening. So yes, that would be really interesting to see. Hopefully no recurrent leaks.
Well, I hope so.
Yeah, and on all that very beautiful Lothrop in that complex patient.
Yeah, exactly.
Quite educational. Yeah.
Yeah, it'd be great to see a nice open cavity in a year's time.
Yeah,
absolutely.
So that's like this,
that's wonderful.
Nice and protected. So I'm going to cover it now with I'll wait a couple of minutes and I'll put the nasopore. So that's like this, is closed now. It's not leaking anymore. So we're going to put nasopore. So I use Nasopore Forte. This is really, I'll show you now. This is quite firm. The two types, Forte is firm, so it's really like stronger, it protects the leak. So it's a bit big here, so I'm going to cut it into two. Let's cut it into two, put one by one. Do that, and maybe you can cut the other one as well. So then we squeeze it, then we put it in very carefully so it doesn't destroy our repair. So I'm squeezing it like this. Then I put it onto the floor first, floor of the nose, then I'll push it up. So it's here. And then I'll push it just to support my leak. So it's underneath the repair. Okay, so right at the back there, and then we can lift it up. Like so. Then put another one. Maybe I need a third one, that's all. Again, same idea, put it on the floor, and then lift it up.
And Hesham, when would you see this patient back in clinic next? So say she does well after 24 hours of admission and gets discharged.
So I'll see you in 2 weeks.
Okay.
Check everything. I don't have to remove anything. I leave them to absorb naturally. Obviously, they blocked. You warned them about this, that they're going to be very blocked in this side until these absorb. And they take about 2 weeks to absorb, but there's always some crusting and all that's after anyway. And I don't actually get them to wash or clear anything for months. I just worry about destroying the repair by if they put too much pressure on the washing or something. So no washing for a month. They get blocked, they get crusty, I don't mind. As long as it's healing. So I put the final one now, and then it's done. So this is the last one. So you can see there's a bit of space here. So it's just basically a strong support for that repair. So the cavity now is full. So she's definitely now supported completely, and obviously that completely blocking the nose as well. So that's done now. There is a space underneath to breathe from anyway. It's not bad. Thank you so much. All done.
Thank you.
Thank you so much,
you.
Hesham. Really interesting case to see, and nice to see the fluorescein coming through, the CSF leak, the repair with the DuraGen, and the DuraSeal over it, and the meticulous searching of the skull base to look for that leak.
Yeah, thank you, Kat. And I think we couldn't have done it without the fluorescein, as simple as that. Couldn't have seen it.
Yeah, very small leak. So
thank you so much. Now we're gonna say bye.
Thank you, Hisham. Thank you from GRN.
Thanks
to you. Really great efforts to organize all this. Thanks to Priscilla, Kat, Mark, then Matthias from the tech team. I can see you took great efforts to organize all this, your theater staff, and everybody, your anesthetists. So really appreciate your efforts. And as far as I mentioned it to Kat, that it takes a whole lot of teams from all these centers. So all the phenomenal efforts to make this event happen. And I was so grateful to all of you for this in supporting GRN. So
thank you very much. And thank you both for moderating very nicely as well. And you take care, and we'll see you for the next one.
See you for the next one.
Great. Thank you very much, Hesham. Cheers now.
Bye.
Bye.
Thank you, everybody.
Kathy.
It was good.
So did you enjoy it, Kathy?
Yeah, really interesting cases today. So fantastic mix that we've seen all the way through. So yeah, great learning and some really interesting tips that we've picked up. So very, very nice. Thank you, Ashok.
And if any of you have missed some of these cases, do check in on our GRN Academy website when they are available as a recording, and we will edit the recording so the cases will be separate to that surgeon, so to be more user friendly. So I think it is time to say thank you to you, Kathy. So you really stepped in almost at a very short notice, and it was great to have you on board with hosting, and you made it really engaging, great discussions, and I hope that got some interesting points out for our viewers. So thank you again, and I look forward to have you again on board.
Thank you very much, Ashok, and thank you for inviting me to take part. It's been a really interesting day, and I've thoroughly enjoyed it. And I will certainly be going to look at the cases I missed from yesterday when I did my clinics, unfortunately. But a great thank you to everybody at GRS. So thank you for setting it all up and organizing everything together.
It's also time to say thank you to all of our scientific committee members and the surgeons who operated and their teams, and also to my GRN team members, especially Dimitri. Dimitri always puts a huge efforts behind the scene. So Dimitri Ionadis, he's another GRN director. So thank you, Dimitri. Then the others who have helped in the past, Rohit, Shri, and Ankur, all of them have always contributed to GRN. And a big thank you to them. Our GRN manager, who does all the admin work, Pam Nori, is also a event organizer for ENT UK and Wessex ENT courses. So she has put a phenomenal efforts. And there were our tech consultants, Dinesh, then the digital infomedia team, Arvin, then putting the beautiful studio, Anil. So all of you, fantastic efforts, and you stayed behind the scene, overseeing this event, almost 12 hours live yesterday. But for them, it is preparation, setting things up, much more than those 12 hours, and they're really working very, very hard. And today, on our second day in a row. So fantastic. Thank you so much. And for Rucha for our digital promotions of the event. And to our delegates for hanging on with us. And I hope you found all the surgical teaching useful. So stay updated, and we'll see you again on our next event. Thank you.
Okay.
Bye for now.
Okay. Bye. Thank you very much.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.